Hello, and welcome to this September episode of Discussing PsA, our psoriatic arthritis podcast series, where we bring you up to date with the latest research and publications in the field of PsA. If you would like more information on the papers we discussed today, please head over to the Immune-Mediated Inflammatory Disease Forum website at www.imidforum.com, where you can view full slide summaries of these publications. Today's discussion will focus on two papers. The first compared the effectiveness and safety of upadacitinib with secukinumab and adalimumab, and the second assessed the efficacy of long-term treatment with risankizumab across the updated GRAPPA domains and key related conditions of psoriatic arthritis. So for the first paper, I'll hand over to Phil.
Thanks very much, Laura. Today's first paper is from Wang et al., entitled Comparative Effectiveness and Safety of Adalimumab, Secukinumab, and Upadacitinib in Psoriatic Arthritis, a prospective cohort study based on Harwich cohort. Just a bit about the background of the study. Introduction of TNF inhibitors such as adalimumab marked a really significant advancement in PsA management by directly targeting TNF. Subsequently, secukinumab, a fully human monoclonal IgG1 antibody that inhibits IL-17A, has been approved for treatment of PsA to further control disease activity and progression. However, pathogenesis of PsA is complex, involving a wide range of immune cell types and signaling pathways. Consequently, therapies targeting a single cytokine may not provide sufficient effectiveness for all patients. Upadacitinib, a selective JAK1 inhibitor, which inhibits several pro-inflammatory cytokines, has demonstrated both efficacy and safety and has been approved for PsA treatment. Wang et al. Is demonstrating real-world evidence for upadacitinib based on data from a Chinese PsA cohort and compared the effectiveness and safety of upadacitinib with secukinumab and adalimumab. This was a prospective cohort study using data from what's known as the Harwich database in China. PsA patients treated with adalimumab, secukinumab, or upadacitinib were included and followed at baseline week 4, 12, and 24. Skin responses were evaluated using PASI 75 or PASI 90 response. Joint outcomes, including peripheral and axial arthritis, were assessed with ACR response, PsA, and ASAS criteria. Patient-reported pain, disease activity, and HAQ scores were also recorded. AEs, adverse events, were monitored throughout treatment. So what did we have? We had a total of 187 PsA patients that were included. All three agents demonstrated comparable effectiveness, improving peripheral joint symptoms and axial involvement. Upadacitinib and secukinumab showed significantly greater effectiveness than adalimumab in improving skin lesions. It's not so much of a surprise with secukinumab, but I think it is important to know how well upadacitinib works in the skin. However, adalimumab was more effective in relieving pain compared to both upadacitinib and secukinumab. Over 24 weeks, 85 adverse events were reported by 48 patients, with fatigue, rash, upper respiratory tract infection, and pruritus being the most common. No serious adverse events occurred. So one comment I want to make about these results before concluding is that I appreciate the effort to do prospective research on these patients that were treated in each of these arms. But one discrepancy I would note, and this may be partly because of the low number of patients, or the smallish number of patients, is that in other studies we've seen upadacitinib working very well and very quickly in the domain of pain. And there's been quite a bit of research on the capability of this small molecule, this JAK inhibitor, to impact pain in ways that some of the larger monoclonal antibodies may not. And so I would say there's some differing stories depending upon the study we're looking at. So to conclude from this overall study, I would comment that upadacitinib and secukinumab demonstrated balanced effectiveness across skin and joint domains, while in this case, adalimumab offered superior pain relief, but we've seen a different story with some other studies. These findings support personalized treatment strategies tailored to the clinical features of PsA patients. Laura, back to you.
Like you said, it makes absolute sense that the secukinumab would be better for skin. That's not a big surprise, but it's nice to have, I think, quite positive data on the skin here. But obviously, these are patients being treated kind of as per usual, which is great for us to get real world evidence on patients that are a bit more reflective of day-to-day practice. But it does mean, presumably, that the doctors are picking those different treatments for other reasons. So it may be that people with more significant skin disease are more likely to be given an IL-17, for example. Maybe those getting upadacitinib have failed more medications before. If this is a relatively new medication, often it's used a bit later, isn't it? So it's really useful to have this real world data, isn't it, outside of the trials and see what happens in normal patients who have comorbidities and problems. But it's tricky when we're comparing drugs and there's, different reasons why their doctor may have picked a particular drug.
Absolutely right. And one of the things I want to also add is that at the upcoming ACR meeting, there's a really interesting abstract that's going to be presented on something called the UPSTAND study. And in this study, patients with axial spondyloarthritis were treated with upadacitinib, and it showed, among other things, terrific effects on pain improvement. But one of the things that was done that was unique in the study was to collect information on different types of pain that PsA patients experience, not only nociceptive pain that's induced by inflammation, but also nociplastic pain using the widespread pain index and symptom severity scale, and the neuropathic pain, so nociplastic pain is central pain, which is separate from peripheral nociception. And then the neuropathic is related to injured nerves. So all three types of pain were seen, and all three types of pain were diminished with the use of upadacitinib. So fascinating to see different ways in which the whole complex narrative of pain is being explored. And so look forward to that at the ACR meeting.
Lovely. Right. Top tips for ACR already, which is great. So I'll now move on to the second paper authored by myself and a number of other colleagues. And this is entitled Efficacy of Risankizumab Across GRAPPA Domains in Psoriatic Arthritis. And it's a pooled analysis of patients from the two phase 3 trials, Keepsake 1 and Keepsake 2. So obviously, GRAPPA has spoken for some years, really, about controlling disease across multiple domains, and that our goal of therapy for patients who have psoriatic arthritis is to achieve the lowest possible level of disease activity across different 6 domains of disease. So arthritis, skin disease, nail disease, enthesitis, dactylitis, and axial disease. And in the latest iteration, we also kind of made more prominent, really, the control of related conditions like IBD and uveitis. It's really important when we're thinking about such a complex condition that we're trying to manage the different aspects of the disease. We know, obviously, that for patients with psoriatic arthritis who have had an inadequate response to conventional DMARDs or even previous biologic DMARDs, risankizumab has been shown to be generally well tolerated and to have significant efficacy at week 24 compared to placebo in the initial trials. And that has a consistent long-term safety and efficacy profile with data now out to around 3 years of treatment. So this particular post-hoc analysis aimed to bring that data together to look at the long-term treatment with risankizumab across multiple GRAPPA domains and those key related conditions of inflammatory bowel disease and the uveitis. So the analysis took data from the phase 3 KEEPSAKE-1 trial with adult patients with psoriatic arthritis in that key phase 3 data. And then they also included data from KEEPSAKE-2, where it was pooled for pre-specified outcomes. So that's particularly for enthesitis and dactylitis, where obviously, the majority of patients may not have that coming into the trial. So to get power, you need to combine from different studies. They looked at outcomes measuring the risankizumab efficacy across key GRAPPA related domains. So arthritis, enthesitis, dactylitis, psoriasis, nail disease, axial disease, and then those PsA related conditions. And that was assessed over 100 weeks of treatment, which is obviously essentially about 2 years. And they also looked at the potential issues in PsA related conditions through adverse events. So if somebody had reported, for example, a flare of uveitis or inflammatory bowel disease, and that was also over that 100-week or 2-year period. So overall, when you look at the patients coming into this analysis, well over 80% of the patients who were randomized to risankizumab completed treatment out to week 100. So you've got the vast majority of the patients in the trial having that 2-year data. And risankizumab, unsurprisingly, given the data that we've seen before, demonstrated efficacy across all of those GRAPPA-defined domains through to 100 weeks. So that included the swollen joint count and tender joint count for arthritis, enthesitis scores, dactylitis scores, and PsA outcomes for psoriasis, nail outcomes, and axial disease. In KEEPSAKE-1, they found that 42% of patients achieved low disease activity, and nearly 63% had reached a minimal clinically important difference in pain at week 100. And the rates of any reports of new onset or flare of pre-existing inflammatory bowel disease or uveitis were very low. And obviously, we know that these drugs are now in development, and some have been licensed for use in inflammatory bowel disease. So we would expect a positive impact of IL-23 inhibitors in bowel disease as well. So this analysis really concluded that treatment with risankizumab provides durable improvement over that 2-year period in signs and symptoms of psoriatic arthritis across the key 6 GRAPPA disease domains and the related conditions of IBD and uveitis. And overall, this post-hoc analysis demonstrated that it delivers durable efficacy across the different domains with kind of expected safety results in line with previous data. And that's for patients who were either conventional DMARD or biologic DMARD inadequate responders prior to coming into the trial. So this obviously is not a surprise. We've seen good data for risankizumab across skin, joints, enthesitis and dactylitis before, but I think it's nice to bring all of that data together and think about the kind of control of domains across the board. There obviously is an ongoing question around axial disease and IL-23. So we've seen consistently in the PsA trials that the BASDAI scores or spinal pain scores do improve. But we know that they're not that specific to axial inflammation. So that may be improvements in enthesitis and quality of life and stuff from treating peripheral disease that gives you that benefit. And so we await further trials looking specifically at axial disease with IL-23 inhibitors. But I think this is really positive, bringing all that data together and thinking about controlling multiple domains for our patients in clinic.
That was terrific, Laura. Very interesting. One of the questions that I find coming up from time to time in clinic is we see quite a lot of patients referred in from the gastroenterologist now, and let's pretend that they're on secukinumab as an example for their inflammatory bowel disease, and that's doing a good job in keeping that controlled. But they have what sort of appears to be a peripheral spondyloarthritis.
Yeah.
So leaving out the spine, let's say they don't have really anything going on in the spine that's problematic. I'm fascinated to know whether if we were to switch to risankizumab alone for management of inflammatory bowel disease, which it does a very good job of, and our gastroenterologists are really loving it for that purpose, how well it might help the peripheral
Mm.
spondyloarthritis in a patient who doesn't have psoriasis. So that's an interesting
Yeah,
question that I've been sort of asking as I see patients coming back on risankizumab who
yeah,
are having improvement of their
yeah.
peripheral manifestations.
Yeah, I mean, I think certainly in clinic, I've seen kind of similar efficacy of drugs as if it was a psoriatic arthritis. Even if they don't have psoriasis, they clearly have a peripheral spondyloarthritis, and you'd expect some sort of similar kind of response. But I think it is a group where we haven't seen a lot of research. And
Exactly.
they're a complicated group.
Yeah.
Even more so if you throw in the axial disease, then when you're looking for drugs that work for axial disease and inflammatory bowel disease, you're down to a pretty limited number at the moment with clear evidence. You've got a bit more flexibility when it's peripheral arthritis or enthesitis or dactylitis. But I think this is a group that really hasn't been studied that well. There was actually a really lovely paper recently from Copenhagen. They've had an inception cohort of their IBD patients running gastroenterology, and then a subset of those were really carefully evaluated by a rheumatologist. And half of the patients who were presenting with new IBD had either joint pain or clinical signs of synovitis or enthesitis, and they've got ultrasound data on those patients and follow-up data on those patients as well. So I think in future publications from that cohort and from other studies, we'll see a bit more data in this group. But they are really tricky, and that's where that co-management is really important, isn't it? To work with the
Yes.
gastroenterologists.
Yeah.
We definitely use that to our advantage to get different doses of drugs. So our gastroenterologists have a lot more flexibility on dosing. Usually their doses are higher. So if we've got somebody who's maybe partially responding and they have inflammatory bowel disease, we can often get the gastroenterologist to check drug levels, to look for anti-drug antibodies, and potentially to escalate up, say, to weekly adalimumab, to higher doses of upadacitinib. They've got a bit more flexibility on their side, which is really useful.
All agreed. That brings us to the conclusion of today's episode. Thank you for joining us for this month's episode of Discussing PsA, brought to you by the Immune-Mediated Inflammatory Disease Forum. If you enjoyed this podcast, don't forget to subscribe to our channels on YouTube, Spotify, SoundCloud, or wherever you get your podcasts. If you want to read more about what we've discussed today, visit www.imidforum.com, where you'll find detailed summary slides of today's publications, as well as our podcast on PsA and axSpA. See you next time.